Welcome to Dr. Choice's M1850 transferring module. In this module, we're going to discuss how to properly score this Oasis item. If you haven't already viewed the module for learning how to properly score the 1800s based on the rules, please make sure you view that before proceeding. Let's take a moment and review the rules for scoring the 1800s. You always score before any interventions. The grade is going to be based on the current safest level or the safest recommended functioning level for this patient. The assessment is based on the day of the assessment within 24 hours. Assistance is defined as physical, verbal, as well as environmental setup. Data will be collected through the interview process and most specifically through direct observation. And ability will be varied based on physical, sensory, cognitive, or emotional factors. In data collection, we're going to obtain that information a couple ways. Questions to the patient and caregiver will give you a baseline of information before you maybe do the observation. Observation is the primary way to gather data, and it should be in a location where the transfer is occurring, such as the bedroom for supine to sit. And if the sitting surface is in the bedroom, you can do that there, or if it's not, then you're going to assess it in the location that is the most common sitting area. Assistance is verbal, physical, or environmental setup, so even maneuvering covers for the patient is considered assistance. And the measure is going to include supine to sit, sit to supine, sit to stand, stand to sit, and or pivoting to the surface they're sitting on. So what if the patient doesn't normally sit next to the bed, or their sitting surface is in another location? Well, you have to assess the patient from their common location. So in that case, you're not going to just consider the bed supine to sit, you're going to consider the sit to stand from the chair that may be in the living room. And in addition to that, you have to include ambulation with a device and any instructions during that ambulation. So 1850 not only encompasses just supine to sit, sit to stand, and pivoting if that's appropriate, it can include ambulation, and during that process, if there's device and instructions, that is part of the grading system of 1850. This is the most common error when being scored in 1850. Majority of patients, not all, but a great majority have a walker or some device and require some verbal instructions, and therefore if that's the case, the scoring of that has to be reflected in the 1850, and we'll take a look at those in a moment. Once we have all the data, the grade that's going to be issued is going to be one based on what would describe the circumstances that provides for the safest current transfer level for this patient. Keep in mind, just because someone can do it doesn't mean they're safe necessarily, and if that's the case, you need to score them at a level that would indicate such, which often is going to be the level below. And if the patient scores 1 to 5, it would be appropriate to have therapy assess this patient and also improve. If you look at the Oasis, you will see the question listed in this fashion. So we're going to take a moment to look at each one of these and what would substantiate the proper answer. So let's take a look at how you would score 0. 0 literally means there is no help whatsoever. You didn't speak to them, you didn't have to help maneuver something for the patient, and they didn't need any physical help whatsoever. This patient literally was in bed and could go supine to sit, not having any issues with medical restrictions, not any issues with falling off or being near the edge of the bed. They could stand up, and they could pivot into the chair with no problems, or they could walk to their surface with no problems, and that surface may be in another room. This also considers that they're not using a device of any sort to do that. So remember, 0 literally means this patient has no help at all and no device in order to transfer. So let's take a look at what 1 indicates. If you're going to select 1 that states that the patient's able to transfer with minimal assistance or with use of a device, you cannot have both conditions to answer 1 on this measure. This is often a mistake when this score is chosen for a patient. So selection 1 indicates that either they have some assistance, again, can be verbal cues, environmental setup, physical assistance, of 25% or less. They do indicate a level here. But listen to this. Any one or a combination of these may make up 25% assistance. Environmental setup is anything from getting the walker for them, setting the brakes in a wheelchair, etc. So keep in mind that you may do 10% of verbal cues and 10% of environmental setup and then 10% physical assistance. That combination can provide a minimal or greater than that, in this case, of assistance. So keep that in mind. It doesn't have to be 25% of physical assistance alone. It can be any combination of that. And if that's all they're receiving is 25% or less of assistance, then 1 would be indicated. Or 1 can be indicated if the patient just needs a device to transfer. This could be a walker or a special lift device. Keep in mind if they sit in a chair in the living room, you're going to look at the device to get to that area. So if they have no assistance at all but do have a device, you could score them a 1. But if they have both conditions, you cannot score them a 1. You have to score them a 2 because the rules indicate that if they have a device and assistance, they have to be scored a 2. This is the most common mistake when answering this question, is that majority of the patients are not sitting next to the bed. The majority of the patients have a chair in another room, and therefore you have to consider that part of the transfer process. So if they have a walker, and let's say they needed very little or no assistance supine to sit, but do need assistance with ambulation and the transfer, then you're going to be including that in the score. And majority of our patients will have some type of assistance, whether it's any one of the 3 things we've spoken of, and a device. So it's very uncommon patients would score 1 on transfers. The majority of the time they're going to be 2, because usually that gait or ambulatory part of the question requires devices for many of our patients. So be careful when answering this question that you look at that aspect. Is this 1 or 2? So let's take a look at a note from Kinzer. When we take a look at this, this is where you can easily take a look at a note and, for the most part, whittle down to what the proper 1850 should be. And this is what the office will do. And keep note that this information that's listed here is very good. It provides a lot of information. But if I look at transfers alone, we're taking a look and say, well, we see that they need moderate assist, so that's already more than the minimum. But let's take a look at this closer. They have a device. There is certainly some assistance on the placement of the leg. There's some pain issues. It already says here the hand spouse to assist lift. That's very good information. There's a device here. And take a look. They're walking 50 feet. So it's unlikely they're sitting next to a chair next to their bed as their common service because they're fairly ambulatory. Now, if it was a couple feet, then you would have to consider that. But we already know they're walking, so it's likely that's going to be part of the score. And then we come down to the sit to stand part of the evaluation. And this, again, there's a lot of information here. So is this a 1? Do they only have a device or only have assistance? No, they have both. So they're going to have to be a 2. And we haven't reached talking about scoring somebody 2, but when they have more than minimum assistance, 2 would be appropriate. So again, this alone tells us that right away. The point I wanted to show on this slide is simply that you can look at the assist, the instructions, and the devices to be able to provide an accurate 1850 score. So let's take a look at 2 a little bit closer. And we just mentioned that if both conditions of 1 are occurring, you have to score them a 2. But 2 also is appropriate if someone is requiring more than 25% of assistance and are able to put some weight bearing into their extremities but cannot complete the transfer without some form of help. So in that scenario, it would be appropriate to score them a 2. This would best be thought of as moderate assistance. So under those 2 conditions, it's appropriate to score somebody a 2. If they need moderate assistance or more than 25%, as well as if they need a device and they need assistance. 2 would be appropriate. But keep in mind that even if the patient's helping out and is not safe, you need to consider that, scoring them appropriately. And in that case, you may not score somebody a 2 even if you're helping them and they're not appearing safe. So in this case, if someone has a weight-bearing precaution on transfers and you're assessing them, remember, safety is integral to ability. So in this scenario, if they require assistance and they can bear some weight, but they're breaking a precaution or a surgical restriction of sorts, and even with instructions, they're still at risk for damaging that surgical procedure, can you say that they are truly safe transferring with assistance? You cannot. It would be appropriate to say that this person's unable to transfer herself and unable to bear weight or pivot when transferred by another person, because that response best indicates their current level of functioning, and that would be the best answer to show where their baseline is at. So keep in mind, when answering that question, you must consider not only their effectiveness on weight bearing, but also looking at the safety aspect of it. 3 is appropriate answer if the patient is unable to bear weight effectively and or needs to be transferred completely by somebody else or a device such as a Hoyer lift. So again, this would illustrate the safest level that this person should transfer, and this would best be described as like max assist. If a patient is transferred via Hoyer lift and can tolerate being out of bed, this would be an appropriate type of answer. What is chair fast and what is bed fast? Chair fast is a person who can tolerate sitting up regardless of the amount of time they are not bed fast. So this means even if they only sit up for 2 minutes, they're still chair fast, even if they spend the majority of time in bed. If you recall from the prior module discussing the 50% rule, it doesn't apply here. If they can be out of bed for any length of time and not adversely be up, then chair fast is appropriate. But bed fast means they're not able to be up out of bed, and this is mainly due to having medical issues once they're vertical. And they could be hypotensive, they could have issues with ALS and multiple system atrophy. They literally cannot tolerate sitting up even for a negligible period of time. It's adverse to them. So keep in mind when looking at chair fast and bed fast, that is a consideration. 1850, let's look at a question here. If a quadriplegic is totally dependent and can't even turn in bed, but they can get up to a jerry chair, are they considered bed fast? What do you think? The answer is no. They can sit up in a chair using a Hoyer lift, though the best answer would be 3. Total assistance. 4 or 5 only applies for a patient who is bed fast, according to Medicare's definition. The frequency of how the person transfers doesn't change the response, only the patient's ability to be transferred and tolerate being out of bed. 4 and 5 indicates the patient can't be out of bed at all without some risk. So therefore, 4 and 5 differ from the standpoint of the patient being able to roll or position themselves safely and effectively in bed. So you must consider the patient's ability to unweigh bony prominences and completely roll from one side to the other in order to take care of any pressure ulcer issues or skin risk. If you have to give any verbal instructions or anything at all, then they are not independent, and therefore 5 would be the appropriate answer. So the difference between these 2 answers lies on the fact of the patient being able to independently and safely and effectively roll and move in bed without help. So let's take a look at an algorithm quickly. It's very simple to look at how you're going to start to score this. First you ask, is the patient bed fast? If they're sitting up, you already know they're not. If they are, then you'd have to look at their ability to either sit up or tolerate being upright. If they're not bed fast, you have to assess if they're safe with no instructions at all or no device. If that's true, then 0 would be the appropriate answer. If they have a device or need some verbal instruction, only one of those, 1 is appropriate. But if they have both, they have to be a 2. Or if they need more than 25% assist, that would be appropriate to score 2 as well. But if you find even under that condition they're not safe with the transfer process and their weight bearing or their braking precautions, then 3 would be the appropriate answer. And if they're bed fast, you'd have to look at whether they can roll or transfer in. Are there other types of transfers considered when looking at this question? The test only is looking at bed-to-chair transfers and not anything else. We do have to consider the patient's transferring with car transfers or even off the floor, and documentation in the record should note that, even though they may not score on this question accordingly. So keep in mind that is something that it is not looking at on this measure. If the patient takes extra time and pushes up with both arms, is this considered using an assisted device? Taking extra time and pushing up with both arms can help ensure the patient's stability and safety during the transfer, but does not mean that the patient is dependent. If standby assistance were necessary to ensure safety, then a different response would apply. So keep in mind, you have to look at how the person is using those armrests to get up. Under normal conditions, many of us just touch the armrest to sit down and stand up. There's nothing wrong with that as part of the chair. But if I'm having to lean heavily and push up very heavily, I'm using it in a different fashion, and that would take a clinical judgment. Sliding board, how do we answer that? If the patient uses a sliding board, you're going to base it still on how they used. You're going to still use the same criteria. So you're only going to score them a 1 if they can transfer with just the device, but no instruction or assist at all. But if they do, then you'd have to go a 2. And you'd have to determine if they require 25% or less when doing that. If they need more than 25% or less, then you may score them a 2. If they cannot effectively weight bear, then you may even look at even a 3. So the sliding board doesn't really change how the scoring system, except the upper extremities are what are being assessed at this point. Looking at this question here, let's find out how you would score this. The patient was toe-touch weight-bearing on the left leg and had pain on the opposite weight-bearing hip. The patient had a history of falls, remained at risk due to medication side effects, balance problems, impaired judgment, weakness, unsteady use of a device, and required assistance to transfer. The concern is safety with the transfers. Considering all of the above, would 2 or 3 be the appropriate answer? Think about how you would score this for a moment. So let's take a look at the answer. The patient would be scored a 2 if they could safely and effectively bear weight and transfer with the assistance of somebody else. But they would be scored a 3 if they could not effectively and safely bear weight on the extremities and transfer with help. So nothing really changes on this, but if you read the description of the question, it sounds like this patient is not very safe, and it sounds like 3 would be the most appropriate answer in this case. Again, look at the safety issue during the transfer process. So what about the case where a patient is no longer sleeping in bed, but they normally sleep in a recliner? It doesn't change the way we answer the question. You will assess the patient from the supine to sit position from that surface, and then go from sit to stand or stand to pivot into the most common sitting surface they would go to, which could be a bedside commode, bench, or chair. How do we score 1850 when the patient is temporarily sleeping in a recliner because the doctor has an order not to climb stairs and the patient's bed is located on the 2nd floor? In this scenario, you have to look at the medical restriction and determine whether the restriction is specific to the condition or does it really change the person's ability in relation to transferring. In this case, the situation of the restriction on climbing stairs wouldn't necessarily impact the person's ability to transfer from a supine to sit position. In this case, you would look at where they're transferring from at the downstairs level. But keep in mind, certain medical restrictions can impact ability, such as an order to maintain strict bed rest, or the patient has a surgical precaution, something directly related to them not being able to do that position or that movement is a medical restriction. In this case, climbing stairs is unrelated to supine to sit or sit to stand. So therefore, you have to look at the medical restriction and how it impacts the patient's ability. So let's take a brief look at the evaluation for therapy, and assistance will be noted in the assist level, and then assist device can be listed there, and if you need more space, you can also go in the comment section below. But that comment section below is one of the most important aspects of making sure we have documentation. It should have information about assistance to the specific parts of the body, verbal instructions of any type, any judgment issues where they're not following surgical or medical precautions. Describe what is going wrong with this transfer that requires services. And the same thing can be said on the sit to stand section as well. Any information that describes the issues related to 1850, such as safety, using gait belts, balance issues, helps provide information so we have documentation supporting that measure. This concludes our M1850 online training. If you have any questions, contact your rehab manager or director of clinical services for any questions you may have.